Good afternoon, everybody. I am Christina. I'm a rising fourth-year medical student here at UCSD, and I am incredibly honored to be kicking off this amazing docket of presentations for this afternoon. So without further ado, let's go ahead and get started. So the title of my master's thesis is Effects of Timing on TransCarotid Artery Revascularization Outcomes. This research was done under the mentorship of Dr. Malas, who is our Chief of Vascular and Endovascular Surgery here at UCSD. I am currently funded under an NIH TL1 grant from the Altman Clinical and Translational Research Institute, and otherwise I have no other financial disclosures besides my mounting medical student debt. A little bit of a roadmap for what I'll be talking about in my presentation. So we'll start with a description of what exactly is TCAR and how this kind of novel surgical method ultimately led to our research question. And then I'll talk a little bit about the sort of data that we use to answer this research question before diving into our results and then having a little bit of a discussion on our findings. And hopefully my presentation will go a little more smoothly than the PhD student on this comic here. So let's start with the disease of interest. So we're interested in atherosclerosis. Now, atherosclerosis is fatty deposits that occur in the walls of our arteries, and they can happen in many different places in our body. However, we're particularly concerned if they happen in the carotid arteries, because if these plaques decide to rupture or embolize, those smaller pieces can travel to our brain and ultimately cause stroke or a baby stroke, also known as a transient ischemic attack. Now, this is a disease that is managed surgically, and ideally we would intervene sooner rather than later, because that way we can prevent recurrent strokes from happening. And you'll see in this chart here, get the mouse up. You'll see in this chart here that patients who received revascularization within 2 weeks of their presenting symptoms had the greatest risk reduction in 5-year recurrent rate of ipsilateral stroke. Now, with this kind of data in mind, surgeons began to perform this procedure earlier and earlier, and then they realized that operating on a freshly symptomatic lesion has extremely high perioperative risks as well. This is data from the National Swedish Vascular Registry, which literally includes every Swedish person in Sweden, so every clinical researcher's pipe dream. And they divided all of their patients into different cohorts depending on when the patient received their surgery. And you'll notice that there were two big findings from this study. The rates of minor stroke and rates of composite mortality, or any stroke, were significantly different between the two groups. And this was really driven by the high rates of complications that we saw within patients who received their surgery within 48 hours. So with these two dates in mind, so 48 hours and 2 weeks, the Society of Vascular Surgery currently recommends our revascularization procedures to be performed within 3 to 14 days of symptom onset. Now, what exactly are our surgical options? So there are 3 currently out there. The first is carotid endarterectomy. This is the open surgical procedure that involves physically going into the artery and removing the plaque in question. This is currently our surgical gold standard. The second is transfemoral carotid artery stenting. Instead of actually removing the plaque, we'll place a stent over the lesion and we'll access your carotid arteries by going through the blood vessels in your legs. Now, transfemoral carotid artery stenting was supposed to be the minimally invasive alternative to endarterectomy. But there were some serious issues with high perioperative risks when compared to endarterectomy patients. Part of this was due to the nature in which the stent was being placed, and we saw a lot of intraoperative and immediately post-operative strokes as a result of that. So TCAR, which is this novel stenting mechanism, was developed to kind of address those issues. You'll see here that in TCAR, we'll access the carotid arteries directly through an incision at your neck. We'll also employ this flow reversal mechanism in which blood flow in the circle of Willis is reversed, so that if the plaque does decide to embolize during the procedure or during stent placement, all of it will be shunted away from the brain and into this kind of filter that you can remove after the procedure. So all of the previous studies that looked at timing focused on endarterectomy and transfemoral stenting, and our study is the first to look at whether timing affects outcomes from TCAR. And really the question is, can we perform TCAR within this urgent 48-hour window that endarterectomy and transfemoral stenting can't seem to do? Our hypothesis, kind of based off of existing literature that looks at TCAR and other embolically high-risk situations, suggests that, yes, TCAR should be able to handle this burden of operating on an acutely symptomatic lesion. And if we can operate on patients within 48 hours, then hopefully that will also lead to long-term decreased risk of mortality and recurrent ipsilateral stroke. So the data that we use from this for this project is the Vascular Quality Initiative. This is a large retrospective database that includes studies from over 600 institutions, and it has great perioperative and intraoperative surgical variables. However, like most of our retrospective databases that exist in the research world, follow-up is extremely limited. Now, VQI is particularly suitable for carotid procedures because they launched the TCAR Surveillance Project back in September of 2016, which really focuses in on the variables and TCAR procedures around the nation so that we can really understand it as a newer vascular procedure. And the statistics that we use include logistic regression and survival analysis. So we included a total of 2,000 patients in our study, and really the takeaway from this table is that patients who received later interventions tended to be sicker. So they had higher rates of coronary artery disease, congestive heart failure, diabetes, et cetera, et cetera. Now, you'll see in this table that we divided our patients into 3 different timing cohorts. The first is really the cohort of interest, this urgent 48-hour period. The second is the Goldilocks period, that is the current recommendation, so anywhere between 3 to 14 days. And the third is patients who received revascularizations 2 weeks after their symptoms. And you'll notice that most of our patients actually received their procedure within this late intervention group, so that became our comparator in our logistic regression. And kind of with that background, let's dive into our results. We found that for our urgent intervention patients, they experienced 3 times increased risk of stroke or TIA after their procedure. And this risk was really mediated by a higher risk of TIA as opposed to a higher risk of stroke. We also found that urgent intervention and early intervention patients had more than 3 times the risk of an adverse discharge, so being discharged to a rehabilitation facility or a nursing home and not being able to go home directly after their procedure. Some other outcomes included in this table that we did not find difference between the 3 groups include in-hospital death, MI, and our composite measures such as stroke or death or stroke death or MI. Here is the results for our 1-year outcomes. We did not find any difference between the 3 groups in terms of mortality at 1 year or recurrent stroke at 1 year. And you'll see that for our survival curves, the 95% confidence intervals for these curves are largely overlapping. Here is the completed results table. So kind of what does this all mean? Unfortunately, it seems like urgent TCAR, like the other carotid procedures, has a higher risk when being performed within this 48-hour window. But it is comforting to know that it's safe immediately outside of this 48-hour window. So anytime between 3 to 14 days, again, the recommended time period, you'll have comparable outcomes to delaying your procedure. Our data also suggests that there might not be any benefit in intervening in our patients urgently or early at all. There are definitely some limitations when it comes to this study, particularly in the discussion of whether there's any long-term benefits. So there was limited 1-year follow-up. Again, it's a retrospective database. Only about 30% of patients had follow-up data at 1 year, so there definitely could be a degree of selection bias in our analysis. Also, our urgent group at 1 year only contained about 40 patients, so there could be a type 2 statistical error as well. And again, this is a retrospective database, but VQI has been extremely well validated and used in over 200 peer-reviewed papers, so its validity is well documented in the literature. Some next steps for our project before we wrap up the analysis portion. One of the suggestions we received was possibly using propensity score matching for our 1-year outcomes. So all of those hazard ratios are unadjusted for covariates, and propensity score matching would allow us to hopefully kind of eliminate the effects of some of those variables. The second thing that we would like to do is use Medicare-linked data to better flesh out our long-term outcomes. Our colleagues at Cornell University University are currently leading a project to link all of our VQI patients to Medicare data. So again, that'll hopefully give us more robust long-term outcomes. And the last question that we had is a different way of cutting the data. So, if a patient does require an urgent intervention, we don't know whether endarterectomy or transfemoral stenting or TCAR is the best option. So that's another project that we will be conducting after this. And with that, I'm happy to take any questions from the audience.
Go first, the judges.
Have there been any comparative studies of outcomes among the three methods?
Not among the three methods, but between endarterectomy and transfemoral stenting, yes. And generally, those studies have found that, so across the board, transfemoral stenting has higher risks than endarterectomy. But this risk is especially high within the first 7 days after presentation. So it'll be interesting to see whether TCAR compares to endarterectomy in a three-way comparison.
Great presentation. 2 questions. How did you select the 2,000 patients?
So we included all the patients who were whose data was collected after the start of the TCAR surveillance project, because that's when a few of the key variables were included in the retrospective database. And we also excluded patients who had more than one lesion, who was receiving a intervention due to trauma or dissection or connective tissue disorders. We also excluded patients who are undergoing a carotid procedure and other concurrent procedures, because those patients tend to have more severe morbidity just because they're on the operating room table for a little bit longer.
So the 2,000 patients, what was the distribution between the 3 categories, or was it all just TCAR?
It was all TCAR. So the three-way comparison is a next step for this study.
So these are everybody with TCAR?
Everybody with TCAR, and we had most of them receiving intervention after 15 days.
Did you include the comorbidities in your logistic regression?
Yes, so we included, we did a combined method of backward selection, and we included variables such as their age at presentation, as well as the degree of stenosis, so the severity of the disease burden, as well as incidence of diabetes and coronary artery disease.
Because in your first table, you indicated that the people who were in the lead group had the severest underlying disease.
Right.
So I'm surprised as to, given that that's the group which is the sickest, that you have worse outcomes in the patients who are treated early.
Right. And I should have said earlier, all of these odds ratios are adjusted for all of those covariates.
My only question was, how many covariates are there in the final model?
I believe we included 6.
That seems reasonable. I was just thinking, because there wasn't very many outcomes for the stroke TIAs, at least in the urgent group. When you total them all up, I guess you had 100 outcomes. So
right.
You probably have 6 to 10 covariates in your model.
Right.
So, no other questions?
All right. Thank you.